Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 189 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, BPO, a 28-year-old female patient presents to her physician's office with boils, for the fourth time in the past 12 months. All previous episodes were caused by methicillin-resistant Staphylococcus aureus, MRSA. The first two episodes were treated successfully with oral clindamycin, however the third episode required linezolid treatment due to a lack of improvement on clindamycin. BPO has smoked cigarettes since the age of 13. BPO is being treated with warfarin for a recent deep vein thrombosis, DVT. BPO's physician would like to try an intravenous IV antibiotic and prefers to treat her as an outpatient if feasible. So my question to you is, which of the regimens listed below would be the most appropriate as outpatient parenteral antibiotic therapy in BPO's clinical scenario? Would it be A. Telavancin 10 mg per kilogram IV once daily for 1 week, or B. Eretavancin 1200 mg IV stat, or C. Dalbavancin 1500 mg IV stat, or would it be D. Ceftaroline 1200 mg IV once daily as a 24-hour continuous IV infusion for 1 week? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Dalbavancin 1500 mg IV stat. A boil is a skin infection that begins as an infected hair follicle or oil gland. Unlike other beta-lactam antibiotics that can be administered as a 24-hour continuous IV infusion for the treatment of methicillin-susceptible Staphylococcus aureus infections, ceftaroline is not stable at room temperature for 24 hours. Therefore, continuous infusion of ceftaroline is not feasible. Ceftaroline is administered every 12 hours for the treatment of skin infections if the patient is unable or unwilling to receive therapy twice daily in the home. Use of the drug will not be feasible without hospital admission because it will be difficult to find an infusion center that is open for 12 hours daily over a 7-day period. Lipoglycopeptides are appropriate for treating MRSA infections, but the drugs are not all the same. Dalbavancin offers a few advantages over other lipoglycopeptides in this patient scenario. First, the infusion time for dalbavancin is only 30 minutes compared with 1 hour for telavancin and 3 hours for eretavancin. Second, unlike telavancin and eretavancin, which can affect the International Normalized Ratio (INR) and activated partial thromboplastin time, abbreviated as APTT, dalbavancin does not interfere with laboratory reporting of INR and APTT values, making INR monitoring during warfarin therapy more accurate in this patient who takes warfarin for DVT. Dalbavancin 1500 mg IV as a one-time dose is the best choice for this patient. Telavancin is on the National Institute for Occupational Safety and Health list of hazardous drugs that are non-antineoplastic agents with primarily adverse reproductive effects. Documentation of a negative pregnancy test is required for women of childbearing age prior to telavancin administration. Therefore, dalbavancin is a better choice than telavancin for this patient. Please advance to the next question. And the next question reads, DMT, a 47-year-old male patient presents to his personal physician for follow-up after starting insulin 4 months ago following poor glycemic control on pharmacologic and non-pharmacologic therapies. He has a past medical history significant for type 2 diabetes mellitus, that is a 7-year history. DMT's A1C has improved from 10.2% to 9.2% since initiating insulin therapy. On physical examination, it is observed that a previously seen small right foot ulcer located below the first metatarsal head has enlarged to 1 cm in diameter. It isn't painful and has minimal surrounding erythema or warmth. Apart from referral to a wound care clinic, which of the strategies listed below would be the most appropriate course of action in DMT's clinical scenario now? Would it be A. Start levofloxacin 750 mg orally once daily plus metronidazole 500 mg orally thrice daily for 10 days, or B. Obtain a swab from the ulcer and prescribe oral antimicrobial therapy once culture results are obtained, or C. Start cephalexin 500 mg orally 4 times daily for 1 week, or would it be D. No antimicrobial therapy is warranted now? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. No antimicrobial therapy is warranted now. Cephalexin 500 mg orally every 6 hours for 7 days is an appropriate initial empiric treatment regimen for a mild diabetic foot infection, but this patient's foot ulcer does not appear to be infected based on the lack of symptoms. The 2012 Infectious Diseases Society of America Diabetic Foot Infection Guidelines emphasize that non-infected ulcers should not be treated with antibiotics. Infected ulcers are identified based on the presence of at least 2 of the following: local swelling and induration, erythema, local tenderness and pain, local warmth, and purulent discharge. This patient may suffer from neuropathy and loss of pain sensation, especially after 7 years of poor glycemic control based on his A1C values, but there are no positive symptoms to justify treating the current ulcer as an active infection. Diagnostic microbiology cultures should never be obtained by swabbing the outer surface of a foot ulcer due to the difficulty differentiating between colonizing and pathogenic bacteria. Microbiology samples should be obtained from deep tissues. Levofloxacin 750 mg orally daily plus metronidazole 500 mg or 400 mg depending on which strength is available orally every 8 hours for 10 days is an appropriate empiric treatment regimen for moderate diabetic foot infections managed as an outpatient. However, this patient's foot ulcer does not appear to be infected based on the lack of symptoms. Please proceed to the next question. And the next question reads, JAF, a middle-aged inpatient is being discharged home after receiving 14 days of IV therapy in the hospital for diabetic foot osteomyelitis managed with transmetatarsal amputation, abbreviated as TMA, of the right foot and subsequent incision and drainage during wound closure. Cultures of samples obtained from the TMA residual margins are positive for MRSA and Escherichia coli. JAF refuses to receive IV antibiotic therapy at home and requests an oral antibiotic regimen. So my question to you is, which of the regimens listed below would be the most appropriate for JAF if the physician would like to complete a total of 42 days of antibiotic treatment? Would it be A. Co-trimoxazole, TMPSMXDS2 tablets orally twice daily, or B. Clindamycin 300 mg orally 4 times daily, or C. Ciprofloxacin 750 mg orally twice daily, or would it be D. Co-amoxiclav 875 mg orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Co-trimoxazole, TMPSMXDS2 tablets orally twice daily. Amoxicillin, clavulanic acid lacks activity against MRSA, so it is not appropriate for this patient. Ciprofloxacin lacks activity against MRSA in the United States. In other countries, MRSA is much more susceptible to ciprofloxacin, and ciprofloxacin is commonly used with or without rifampin to treat staphylococcal bone and joint infections caused by MRSA. Clindamycin lacks activity against Escherichia coli, although it provides coverage for MRSA. A D test of inducible clindamycin resistance must be performed for all staphylococcal isolates. Clindamycin is an acceptable oral alternative for the treatment of bone and joint infections, including diabetic foot infections, caused by MRSA if inducible clindamycin resistance is not detected. However, clindamycin is not appropriate for this patient because of the presence of E. coli in cultures. TMPSMX provides coverage against both MRSA and Escherichia coli, and 2 double-strength tablets twice daily is an appropriate oral regimen for the treatment of bone and joint infections, including diabetic foot infections. Please progress to the next question. And the next question reads, JLR, a 3-year-old boy and his mother present to the Pediatric Accident and Emergency Department. He is reluctant to bear weight. His vitals include a maximum body temperature of 40 degrees Celsius since a visit to his primary care provider, PCP 48 hours ago with a complaint of hip pain. JLR's mother informs the pediatrician that he was playing on a merry-go-round last weekend but he has no recent trauma or injury. His initial labs include an ESR of 120 mm per hour, a CRP of 25 mg per liter, a WBC count of 22,000 cells per microliter. The orthopedic surgery team has been consulted, and JLR will be evaluated for drainable foci of septic arthritis or osteomyelitis based on preliminary imaging findings. Cultures of blood samples obtained during the PCP office visit are still negative. So my question to you is, which of the IV regimens listed below would be the most appropriate to initiate in JLR's clinical scenario until final culture results are obtained? Would it be A. Ampicillin, sulbactam 50 mg per kilogram, based on ampicillin component, 4 times daily, or B. Clindamycin 10 mg per kilogram 4 times daily, or C. Clindamycin 10 mg per kilogram thrice daily and ceftriaxone 75 mg per kilogram once daily, or would it be D. Vancomycin 20 mg per kilogram 4 times daily plus ampicillin 50 mg per kilogram 4 times daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Clindamycin 10 mg per kilogram thrice daily and ceftriaxone 75 mg per kilogram once daily. Empiric antimicrobial coverage should be provided both for gram-negative pathogens, most likely Haemophilus influenza H, influenza, or Shigella kingi, and gram-positive organisms, methicillin-susceptible Staphylococcus aureus (MSSA) and methicillin-resistant Staphylococcus aureus (MRSA) until culture results are finalized because of the increased prevalence of these gram-negative pathogens and Staphylococcus species in patients like JLR who are less than 4 years of age with a musculoskeletal infection. Clindamycin is appropriate to start now in the absence of bacteremia. It is considered the drug of choice to provide coverage for both MRSA and MSSA pending adequate source control, which may be achieved via aspiration of joint fluid in this scenario. Ceftriaxone is preferred as the second agent for empiric coverage of both Shigella and Haemophilus influenza until speciation of fluid cultures is performed, at which time the coverage could be narrowed to ampicillin or clindamycin monotherapy depending on microbiologic findings. Vancomycin and ampicillin is not the best choice because of recent increases in prevalence of ampicillin-resistant Escherichia coli and beta-lactamase producing Haemophilus influenza and the inferior efficacy of vancomycin and ampicillin for MSSA treatment compared with clindamycin and ceftriaxone. Empiric clindamycin monotherapy would not be appropriate even in the absence of positive blood cultures because it does not provide the gram-negative coverage needed for patients in this age group with musculoskeletal infections. Ampicillin, sulbactam would provide coverage for MSSA, Shigella, and beta-lactamase producing Haemophilus influenza. However, coverage for MRSA would be lacking. Therefore, ampicillin, sulbactam is not appropriate. Please advance to the next question. And the next question reads, BZK, a 12-year-old adolescent male patient who is now on day 5 of cefazolin 50 mg per kilogram IV thrice daily for the treatment of acute osteomyelitis caused by MSSA. The pediatrician plans treatment for a total of 6 weeks. Blood cultures are negative since the 3rd day after admission. His CRP was 15 mg per liter on admission, and is now 4 mg per liter after drainage and 4 days of antibiotic therapy. On physical examination, it is established that BZK's ability to ambulate is beginning to improve. He has a pain score of 2/10 on the FACES pain scale. BZK can tolerate oral medications and nutrition. So my question to you is, which of the therapeutic recommendations listed below would be the most appropriate now for BZK? Would it be A. Continue cefazolin 50 mg per kilogram IV thrice daily for a total of 14 days, then transition to cephalexin 33 mg per kilogram orally thrice daily for the remaining days of treatment, or B. Transition to co-trimoxazole 5 mg of the trimethoprim component kilogram orally twice daily for the remaining days of treatment, or C. Transition to nafcillin 50 mg per kilogram IV 4 times daily for the remaining days of treatment, or would it be D. Transition to cefadroxil 15 mg per kilogram orally twice daily for the remaining days of treatment? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Transition to cefadroxil 15 mg per kilogram orally twice daily for the remaining days of treatment. In pediatric patients with acute osteomyelitis, transition from IV to oral antibiotic therapy can be attempted if the patient can tolerate oral or enteral medications, and improvement in pain and other symptoms and a decline in acute inflammatory markers have been demonstrated. Using the IV route for the entire duration of antibiotic treatment is not linked to improved outcomes compared with IV followed by oral therapy in this patient population. Transitioning to cefadroxil 15 mg per kilogram orally every 12 hours for the remaining days of treatment is appropriate for BZK. Trimethoprim, sulfamethoxazole 5 mg of the trimethoprim component per kilogram orally every 12 hours is useful in patients less than 5 years of age with acute osteomyelitis who may harbor gram-negative pathogens, but it is not preferred for BZK whose pathogen has been isolated MSSA and whose symptoms are improving. There is no minimum number of days of IV therapy required before switching to oral therapy. The decision to switch is based on symptom resolution. Please advance to the next question. And the next question reads, a lumbar puncture, LP, was performed for BMW, a patient presenting to your accident and emergency department with suspected meningitis. The table below lists the cell count from the cerebrospinal fluid (CSF) analysis and the CSF glucose and protein concentrations. The results to date of cultures of CSF samples sent to the lab remain negative, but the final results are still pending. The opening pressure was reported to be less than 200 mm of mercury, and the CSF was reported to be clear in appearance. Pause the video and closely scrutinize the table, which will be useful in answering the next question. So my question to you is, which of the following is the most likely etiology of this patient's meningitis? Is it A. viral, or B. tubercular, or fungal, or is it D. bacterial? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Viral. CSF cell counts that show mononuclear predominance, protein less than 200 mg per deciliter, and glucose greater than 45 mg per deciliter are commonly associated with viral, not bacterial or fungal or tubercular, meningitis or encephalitis. Additionally, the opening pressure was normal. CNS opening pressure is most often normal in the setting of viral encephalitis. Please advance to the next question. And the next question reads, TJM, is a 17-year-old female patient with no significant past medical history who presents to the student health facility after learning that her college dormitory roommate was diagnosed with meningococcal meningitis. She has no known drug or food allergies or intolerances. TJM is not currently taking any prescription medications. Considering her exposure to an infected individual, which of the strategies listed below would be the most appropriate recommendation or course of action for TJM now? Would it be A. Ensure that TJM is up to date on all vaccines as part of routine preventive medicine, but no pharmacologic prophylaxis is needed regardless of her meningococcal immunization status, or B. Inquire whether TJM has received the recommended meningococcal immunizations, and if she has been immunized, no pharmacologic prophylaxis is needed at this time, or C. Advise TJM to avoid contact with her roommate for 1 week, but no pharmacologic prophylaxis is needed at this time regardless of her meningococcal immunization status unless TJM begins to show signs or symptoms of meningitis, or would it be D. Give a one-time 500 mg oral dose of ciprofloxacin to TJM as prophylaxis regardless of her meningococcal immunization status. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Give a one-time 500 mg oral dose of ciprofloxacin to TJM as prophylaxis regardless of her meningococcal immunization status. The Centers for Disease Control and Prevention Advisory Committee on Immunization Practices recommendations on the control and prevention of meningococcal disease recommends pharmacologic prophylaxis for all persons exposed to an index case, regardless of vaccine status. A one-time oral 500 mg dose of ciprofloxacin is among the prophylactic options. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 190.